Dr. Bhuvan Chanana, who will be talking on GRT management, tips and approach.
So very good afternoon, and thank you chairpersons and AIOS for giving me this opportunity. So I think GRT is a condition which can be mostly managed through vitrectomy only. I think it's difficult to do a scleral buckling in most of the cases, although I also do a lot of scleral buckling. So I'll just be going very fast because I have few videos and few tips which I just want to share. So I think we all know that a GRT or a giant retinal tear is a break which is more than 3 clock hours. So what are the treatment challenges? So the main thing is that it is a unique in presentation. Because of their size, it can have radial extensions, it can lead to severe PVR, and it can also lead to higher chances of redetachments and failures. So how to prevent this? So the first challenge is whether we have to sacrifice the lens or not. I think with improvement in the technology, with the smaller size, wider view, we can mostly save the lens in most of the cases, but sometimes it is better to be compromise the lens if it is cataractus, you're having a difficulty in doing the anterior vitrectomy, if it is associated with severe proliferation of anteriorly, or in a case of a redetachment, then it's always better to remove the lens and do a good vitreous base dissection. So this is one of the first videos which I did. This is a 20 gauge vitrectomy, so a very old video. So you can see it's very important to do a complete vitrectomy, especially along the edges. PFCL is like a third hand in GRT, it's very essential. So it's very important to remove all the epiretinal membranes which are present at the edges. That's very important for all retinal detachments. So you have to release all these membranes which are attached. So in this case, I'm using the endolite and the cutter to separate the forceps. Then I removed the lens as it was cataractus. So this was a traumatic case, a young child. You can see this is a near total giant retinal tear. A very good dissection is very essential along the edges of the GRT. Further removal of the membranes which are present infero-nasally, then a complete fill of PFCL. It's very important to have a complete fill. You should have the PFCL coming into the infusion cannula. You also have to be careful that the IOP is not very high, and following a complete fattening, there should be absolute dry edges. You should do around 3 to 4 minimum layers of 360-degree endo laser all around the GRT. And I usually do not do a PFO silicone oil direct exchange. I prefer to do a air exchange to see whether there is any slippage or not. And then probably you can also use gas or you can inject silicone oil. But this was an old case, I injected silicone oil. So whether the use of encirclage or not, I personally do not use it in simple cases. Probably if there is a lot of anterior PVR, I will use an encircling agent because it can lead to slippage. But some of the factors which favor they say that it supports the vitreous base and can increase the success rate. But I will use it in a case only when there is extensive PVR. So how to prevent slippage? As I said, a very good vitreous base dissection, a complete dissection attachment of the vitreous along the edges, a complete PFCL fill to have a dry edge, and you can also try a direct PFO silicone oil exchange rather than doing a air exchange, which I usually don't do. So this is another video. In this I wanted to highlight a technique. So this is one important tip which I have learned and I also read, that these small radial extensions, if you give it, they really help to reduce the traction, the radial traction, and increase the success rate. So I'm removing the anterior edge of the retina because sometimes it can lead to neovascularization. So these are the small radial cuts which now I routinely give in all GRT patients. It really reduces the chances of the slippage and the flap rolling back. So I'll just tell you the logic behind these radial cuts. And I also went through the books, and it's already mentioned in the Ryan that radial cuts are very important for prevention of slippage. This is followed by endo laser and silicone oil injection. So there are two types of tractions which are happening. One is a tangential traction and one is a radial traction. When both of them are more than the force of attachment, then it will lead to a slippage or a chances of a redetachment. So what happens with this radial relaxing retinotomy is we are releasing the radial traction as well as the tangential traction and trying to make the force of attachment either more or equal to it. So the small radial extensions along the edges and maybe 1 or 2 in between the retina, they really have increased my success rate and decreased the chances of slippage. if I do a air fluid exchange or redetachment rates also. So I think this is the most important thing which I wanted to tell through this presentation. Now this is the second most important thing. This is the last video, it's a bit long video. So this is a case which has got severe PVR, a gone case. I didn't want to operate, but the patient really wanted to go surgery. You can see the bare choroid. In this patient there is extensive PVR, the retina is just completely rolled up. So this is something, a hope surgery I'm doing. So I'm trying to, after doing a vitrectomy, I'm just gently removing the membranes. There was a site of retinal incarceration which can be seen because this is a traumatic one. So just removing the area of the retinal incarceration, injecting some PFCL to get some surgical space, and gradually removing these proliferative membranes and trying to open up the retina. So what I observed is that I think if you're very patient and you go very slow, maybe in some cases you might achieve some success. So there is a lot of contracture here. So here I decided that I should probably do a relaxing retinectomy. I did a retinectomy, I've injected PFCL, and now I'm doing a removal of the ILM to further try to relieve the traction at the posterior pole. You can see the fovea is just displaced below the disc. There is so much PVR. So after releasing all the peripheral membranes, doing some retinectomy, I did this removal of the ILM, which was very boggy and tightly adherent. Further retinectomy. So in this case, I decided to leave PFCL. So now this I do routinely in severely cases with PVR D3. I leave PFCL as a temporary tamponading agent. So under PFCL, I've done laser. I've left PFCL, and after about 10 to 15 days, you can see the mark change under PFCL. So the fovea is coming back to its normal position. Removal of residual membranes which are there. Now what I'll do, I'll remove this PFCL. For 15 days, PFCL will not cause any problem. And then I'll replace it by, I'll do an air fluid exchange again to look for any slippage, and I put silicone oil. So the anatomy has improved so markedly. This is the first intraoperative picture, and this is the second. You can see the fovea is coming back to its position, and the retina is looking much better. So I use this two-stage technique even in severe cases of PVR. The OCT picture has become normal, the retina has become normal, and the patient has also gained some vision in these cases. So not only in such poor cases, but also in any RD with PVR D3, I now routinely use PFCL as a temporary agent and do a second setting surgery after about 14 days, remove the PFCL, and it has really increased the success rates. So just to conclude, I think successful management of GRTs, the main thing is a very good vitrectomy, a good vitreous-based dissection, removal of all the vitreous attachments at the edges of the break. PFCL is very important. You have to have a complete dry edge. PFCL should come up to the infusion cannula, a good laser, and PFCL can now also be used as a temporary tamponading agent. Relaxing radial retinotomies have also really released the radial and the anterior-posterior traction as well as the tangential traction and increase the success rates. So thank you.
Thank you. Thank you, Dr. Chanana. This is GRT is one condition we cannot do scleral buckling in. I tried in the initial stages, pre-vitrectomy era, and the retina settled for about 3 months, 4 months, ultimately gave way. So it cannot be done. What are your success rates?
So it depends. See, if a fresh GRT comes to me, I think the success rate with a vitrectomy would be more than 90%. But such case, if there is severe PVR, then it's very difficult to predict a success rate. Maybe even if a 10 out of, even if I give 2 patients some vision, I think I'd be
Some
very lucky.
ambulatory vision.
Yeah.
Thank you. Nice surgery, sir.
Okay, one question.
Yeah. I don't use bands. In fact, I don't even think now for anterior PVR I would use a band. What I would do is rather do a retinectomy, relaxing retinectomies, and a PFCL tamponade. So I personally do not recommend to use a Fencer clutch, but some surgeons use it, so I just wanted to tell the indication.